Welcome to Clinical Minute. Mai is a 29-year-old woman and the new mother of an 8-month-old boy. She has scheduled an appointment with you to address the recent onset of terrible pain in her sacral area, as well as the left lower quadrant of her back. In response to your questions about triggers and timing, Mai tells you that the pain is worse about 1.5 weeks before her period and continues throughout her menses. Mai also tells you that she has occasional dyspareunia, especially during or just before her period. Taking nonsteroidal anti-inflammatory drugs, or NSAIDs, only provides mild relief, and sometimes Mai has to resort to Tylenol number 3. When you ask about the birth of her son, Mai says that she had a very easy pregnancy with a vaginal delivery. She breastfed for the first 6 months and currently uses continuous combination hormonal contraceptives for birth control. When you ask about previous pelvic pain associated with her menstrual cycle, Mai recalls a history of perimenstrual pain that began when she was around 19. Mai sought medical care at that time and reports that she took the pill, which was pretty effective in relieving the pain. Mai tells you that during her pregnancy she was pain-free for the first time in 10 years. She is discouraged that the pain has returned and asks if it could be all in her head. Considering Mai's medical history and symptoms, you suspect she has endometriosis. You perform a physical exam to rule out other conditions and ensure that Mai is in good health. Mai is slender but well-nourished, and physical findings are unremarkable. However, when you perform a pelvic exam, you note a retroverted uterus that is tender to palpation, and tender nodular masses along thickened uterosacral ligaments. The external genitalia, cervix, and vaginal mucosa are unremarkable. Mai schedules a follow-up appointment in 1 week to review her lab results, which include a CBC, pregnancy test, and a pap smear. The results of Mai's lab tests are all negative. Mai expresses relief that nothing serious is wrong with her, but again asks, "Is this pain all in my head?" You explain to Mai that you suspect she has endometriosis. You reassure her that her condition is not in her head, and briefly review the common symptoms of endometriosis, including cyclic chronic pelvic pain, dysmenorrhea, dyspareunia, deep pelvic pain, lower abdominal back or loin pain, and pain when urinating or having a bowel movement. You also explain that endometriosis is estimated to affect about 5 to 10% of women in the United States, and the mean age at diagnosis is 28 years old. At first, Mai's face relaxes when she realizes that her condition is a real medical problem. Then her expression changes to one of concern. Mai's eyes fill with tears, and she asks, "Why do I have endometriosis? And does this mean I can't have any more children?" You briefly explain that endometriosis is common, affecting about 1 in 15 women. A number of factors are thought to increase a woman's risk of endometriosis, including having a first-degree relative with endometriosis, early age at menarche, and no history of pregnancy or breastfeeding. You emphasize to Mai that these factors are correlated with the risk of endometriosis, but the strength of the correlation is not strong. Also, there is not evidence to suggest that these factors are causes for endometriosis. You point out to Mai that she has none of these risk factors, but you strongly suspect that she has endometriosis. You also explain that endometriosis can cause infertility, but add that 50% to 70% of women with endometriosis are not infertile. You discuss next steps with Mai and explain that the most accurate way to determine if she has endometriosis is to perform laparoscopic surgery. This is a procedure where a thin, lighted tube is inserted into a small incision in the stomach for direct visualization of organs in the abdomen and pelvis. You explain that laparoscopy allows the surgeon to see any lesions that might be associated with endometriosis. You tell Mai that laparoscopic surgery will rule out other conditions that might be causing her pain, such as gastrointestinal, urinary tract, or other gynecologic disorders. The procedure will allow you to establish a diagnosis and determine the severity of her endometriosis. The surgeon may be able to remove endometriotic lesions during the procedure, which could result in relief of Mai's pelvic pain. Mai grimaces when you describe the laparoscopic procedure and asks if it is really necessary. She tells you that it sounds pretty awful. Mai asks if other treatments are available for endometriosis because she does not want to live in pain. You explain that medications are often used to effectively treat endometriosis, including continuous combination hormonal contraceptives, progestins, and GnRH agonists. You tell Mai that these options can effectively relieve the pain caused by endometriosis and will prevent her from getting pregnant. You also offer reassurance that these medications will not prevent her from conceiving in the future, since their fertility effects are reversible once a woman stops taking them. Since continuous combination hormonal contraceptives no longer provide effective relief of Mai's symptoms, you recommend luprolide acetate 3.75, a GnRH agonist. Gonadotropin-releasing hormone agonists, or GnRH agonists, are more potent inhibitors of gonadotropin-releasing hormone. GnRH agonists result in a hypoestrogenic environment through the inhibition of gonadotropins. Because of the loss of bone mineral density, the recommended duration of treatment is limited to 6 months. Treatment with progestins or continuous combination hormonal contraceptives could be used as add-back therapy if bone density issues are a concern. Side effects of GnRH agonists can include hot flashes, vaginal dryness, emotional lability, and decreased libido. GnRH agonists are approved by the FDA for the treatment of endometriosis. Mai takes luprolide acetate 3.75 for 3 months and then schedules an appointment to report that it is not working for her. While she is experiencing pain relief, Mai also has terrible headaches and flushing for the first week after each monthly injection. These side effects have diminished with time, but Mai decides that she wants to stop using the GnRH agonist. She recalls that you had mentioned that the lesions caused by endometriosis could be removed during laparoscopic surgery. She is now thinking that surgery is a better choice for her, especially since she wants to be as healthy as possible before she tries to conceive a second child. The American Society for Reproductive Medicine has developed a classification system for endometriosis based on stage of disease. Points are assigned to laparoscopic findings, including the extent of the lesions, density of pelvic adhesions, involvement of pelvic organs, and degree of fallopian tube occlusion, to classify 4 stages of endometriosis. Stage 1, or minimal endometriosis, 1 to 5 points. Stage 2, or mild endometriosis, 6 to 15 points. Stage 3, or moderate endometriosis, 16 to 40 points. Stage 4, or severe endometriosis, greater than 40 points. You refer Mai to a surgical gynecologist, and she undergoes laparoscopic surgery with adhesion, lysis, and lesion ablation. Laparoscopic findings reveal deep endometriosis in the peritoneum, greater than 3 centimeters, 6 points. Superficial endometriosis on the right ovary, less than 1 centimeter, 1 point. Filmy adhesions on the right ovary, 1 point. Superficial endometriosis on the left ovary, less than 1 centimeter, 1 point. With a total score of 9, Mai is diagnosed with mild or stage 2 endometriosis. Following surgery, Mai resumes use of continuous combination hormonal contraceptives for birth control. At her annual wellness appointment, Mai is clearly excited and happy. She indicates that she has had no pain with her menstrual cycles since her laparoscopic procedure, and no dyspareunia. In addition, Mai tells you that she stopped using contraception about 3 months ago. She laughs as she says she thinks she may be pregnant since her period is 10 days late. You perform a physical exam and a urine pregnancy test, which comes back positive. Mai is elated and cannot wait to tell her husband. She says, "I never thought I would be able to get pregnant again after I was diagnosed with endometriosis, but it all turned out great." You congratulate Mai and remind her to schedule a prenatal visit. With a beaming smile, Mai promises to bring her young son and her new baby for a visit very soon.